Hey everyone, let's talk about the arm. All right, the agenda. We're going to start talking about bones and muscles. We're going to work proximal to distal, so starting at the shoulder and ending at the fingers. Then we're going to talk about long, stringy things with an emphasis on nerves and nerve injuries. I really think that's where majority of your NBME questions are going to come in. Briefly, we're going to talk about arteries and then veins. Starting at the shoulder, okay, so we have the clavicle and the coracoid and the anterior. The acromion is the sort of highest point of your shoulder. Think of like Athens. The Acropolis is the highest part of the city. Acro, high, polis, city. So here, acro, high, mion is shoulders, the highest part of the shoulder. The humerus of the arm connects to the shoulder below the scapula at the glenohumeral joint. So just colloquially, we use arm just to talk about the whole, the whole arm. But anatomically, arm really just referring to this upper portion here. And then the forearm actually talks about this portion down here, which is made up of the radius and the ulna. And then, of course, we have our hand with our carpals, metacarpals, and phalanges. Just note the anterior versus posterior view and try to become very familiar with it because it's going to become important as we proceed through the lecture. The proximal part of the humerus, where it attaches to the scapula at the glenohumeral joint, the lesser tubercle is on the anterior side. It's lesser because it's smaller and because it connects to less muscles. Really just the serratus anterior is the main one. The greater tubercle is going to connect. It's greater because it connects to more muscles, and it's also just, it's larger. So this is going to be on the posterior. Now, between the two tubercles is the intertubercular sulcus being like a depression or a groove. It's also where the bicipital tendon of the long head sort of snakes through. So it's also known as the bicipital groove. If you have damage to certain parts of the humerus, this can be associated with different nerve injuries. I find this high yield. So if you have damage at the surgical neck, this is associated with the axillary nerve. If you have damage at the mid-shaft, or really the mid-shaft to the upper 2/3, this is where the radial nerve snakes around to the lateral side. This is associated with the radial nerve. If you have damage to the medial epicondyle, that's associated with the medial nerve. Technically, it's a little bit like the supracondylar region, but for the most part, we can just think of it as the medial epicondyle. And the ulnar is also going to be associated with this region there. Theoretically, the radial nerve could also be associated with the lateral epicondyle, but I think probably they'd say a mid-shaft fracture for the radial nerve. So the distal portion of the humerus is going to connect to the radius and the ulna, and it has these two large projections, these medial and lateral epicondyles, and this is where a lot of muscles that are going to be really important in the forearm are going to connect to. So in the anterior part of the forearm, we have our flexors. They're going to attach to the medial epicondyle, and in the posterior part of the forearm is where we have our extensors. These are going to connect to the lateral epicondyle. This will be very important, and we'll circle back to this again and again and again. Just can't say it enough. So the radius is lateral and the ulna is medial. I think of that because, ulna is a smaller word and the pinky is smaller, so that goes with the word ulna. Or I think of like the human, and like Da Vinci's anatomical drawing of a man, and just think of, the radius is going to be closer to the radial bone. So, whatever way sticks in your head, just to make sure you know which one's lateral, which one's medial. And when I'm referencing these, lateral and medial, I'm almost always assuming that we're in anatomical position seen here, where the palms are facing anteriorly. So at the elbow joint, the ulna is going to be larger, and it plays a more important role in articulation for the elbow. On the anterior, we have the coronoid process, and on the posterior, we have the olecranon process. So the elbow joint, just a little bit more. Again, we have the coronoid process on the anterior of the ulna, and the olecranon is going to be on the posterior. So that's like the pointy, sticky outy thing when you rest your elbows on the table. That is the olecranon that you are resting on the table. It fits into the semilunar notch of the humerus. Technically, it connects to the trochlea over here, and then the radius is going to connect to the capitulum. You can think of the elbow as a pivot point. So think back to physics with torque and everything. So this is our pivot point right here, and the bicep is going to insert right here, the radial tuberosity, and it's going to pull upwards. and the triceps going to connect to the olecranon over here. And so this would produce sort of like a clockwise torque, and this would produce a counterclockwise torque. And well, that's really going to be the motions that we see, the flexion and the extension at the elbow joint, these antagonistic motions between the bicep and the tricep. Also keep in mind the formula for torque. This is really just more like a fun fact, but you can think of this as like a really poor mechanical advantage. The more torque, the more distance you have from the pivot point, the more torque you get. But look, the distance here is really, really, really small. So this is actually a really poor machine, honestly. I'm sure there's like trade-offs evolutionary, and that's why we evolved this way. But it takes a tremendous amount of force to get any sort of torque up and down, because again, we're so close to the pivot point. It'd be better if it was pulling up here or something like that. You don't need to know that formula, of course. I just found that interesting, a nice tie-in. All right, starting with the muscles now. From the superficial layer, we have the deltoid here, and we can remove this. This is associated with the deltoid tuberosity. I would know that. I wouldn't know this one as much. We'll talk about that later when we do the chest, but the pectoralis major is technically attached to the crest of the greater tubercle. All right, so now moving a little bit deeper, looking at the rotator cuff, or shoulder muscles. On the posterior, we're going to have the teres minis, infraspinatus, and then supraspinatus. And then on the end, and those are all, of course, attached to the greater tubercle on the posterior side of the humerus. Then on the anterior side, we're going to have the subscapularis, which is attaching to the greater tubercle, and then between the lesser tubercle there and the greater tubercle there, we have the intertubercular groove, also known as the bicipital groove, where the long head of the biceps brachii snakes through. The triceps, because it has three heads. It has a long head, a lateral head, and a medial head. The long head is, well, the longest. The lateral head is on the lateral side, and the medial head, this one's always kind of weird. It's kind of on the medial side. It actually snakes around. I would say it's more it's a little bit deeper. It's on the anterior part, or the deeper part of the triceps. Which is really not that important, but it always confused me. So you can see a little video of it here. So starting the insertion site here is the olecranon of the ulna. So let's go ahead and take a look at the long head. You can see it's longer. That's why it's called long head, and that's the lateral head. It's on the lateral side. And then the medial one right there, and we're going to circle around. Look at that camera work. Yeah, it's a little bit deep. It's really not that important, but there you go. So a lot of the actions of muscles should be straightforward if you just think about where the origin is and where the insertion is. Keep in mind that the origin is typically going to be the more proximal attachment site, and the insertion is going to be the more distal attachment site. So you can kind of like conclude logically what the action of a muscle should be if you just imagine what would happen if the insertion point moves closer, becomes shorter to the origin site. So the two major ones for the long head were attaching to the infraglenoid fossa. So the glenohumeral capsule is really just where these things attach. So infra below, glenoid below the glenoid point, and then fossa is like a depression of the scapula. So the name kind of makes sense. This one's not so important. It's really just in the middle of the humerus, technically superior to the radial groove where the radius snakes around and comes down the arm. And then the insertion is here at the olecranon. So if the olecranon here was to become tighter and sort of move up, it's going to, as we just saw in the last picture, pull the elbow down. So we get this motion here. We're really just making the muscle shorter. The origin stays where it is. The insertion gets shorter, and that is the natural consequence, just from a physics perspective. Biceps, we all know what biceps are, because there's two of them. We have the long head. The long head, because if you just think of a triangle, it's sort of like doing that direction. And then the short head is really just the hypotenuse. So the total distance that the short head goes is less than the distance that the long head is going to do right here. So this is the long head, and this is the short head, like that and like this. So let's take a deeper look at this. We have the coracoid, not to be confused with the coronoid. So coracoid is right here. Coronoid is the anterior part of the ulna. So this is the supraglenoid fossa, which is where the long head of the bicep is attaching to, and the short head is attaching to the coracoid process. they're both inserting onto the radial tuberosity of the radius. And if we just want to get a look at everything that's going on here, we have our long head, we have our short head, take them away, get rid of the deltoid. Here we have the brachialis. It's really doing the same thing as the bicep, helping flex the elbow. And then the coracobrachialis, which is pretty small, doesn't really do that much. I wouldn't worry about it too much, but it just plays a mild role in adduction. All right, so again, if we kind of just play out the logic, we have our origins here. Why are these the origins? Because they're more proximal. The distal one is going to become shorter at the radial tuberosity. The natural motion would be flexion of the elbow. So there's, again, like I said, there's more than just the bicep. There's the biceps, there's the brachialis, and then there's also the brachioradialis, all helping with flexion. So let's take a look at this here. Okay. Brachialis behind it, more deep. And then we have the brachioradialis, which insertion point is way, way, way down on the arm. It's way distal compared to the other ones. So we saw this picture earlier, but actually what's going on with flexion is more like this. The brachialis and the biceps insert at similar points on the forearm. The brachioradialis, you would think theoretically that there's a large mechanical advantage to the brachioradialis because the distance is so far from the pivot point. But more realistically, it's a smaller muscle, and it's actually probably, we also have to think about the angle. It's probably not tangential to the circular motion that we want, so it doesn't actually provide the full torque. But anyways, that's not going to be on the test. Supination, pronation. Supination, I imagine you're holding a bowl of soup. Look at her hands. That's how you would hold a soup. So any motion that achieves this or holds this, that is supination. Pronation is going to be the exact opposite. So what this kid is doing right here, he is pronating when he's trying to slap his sister's hands, right? Pronation. There you go. So the biceps also help supinate. We know biceps is arm, elbow flexion, but also supination is an important role too. And so it's kind of tricky. It's sneaking under into the radius, and it's kind of pulling it over. It's really hard to see. And it's just rotating it. Now, it's also being helped by the supinator muscle, shown right there. Moving on to the forearm, and then the hand and the fingers. So at the elbow, it's the ulna, which is sort of the head honcho. It's the larger one. It articulates more directly with the humerus. But at the wrist, that flips. Now the radius is larger, and it's articulating more directly with the carpal bones. So if you're going to break your radius, I guess there's two different ways you could do it. 90% of them are going to be called a Coles fracture. This is where you fall on an outstretched hand. Now, alternatively, you could, sort of fall on a flexed hand like this. That would be a Smith fracture. I don't know how relevant this is. In jiu-jitsu, apparently, this is a better way to submit your opponent. I guess there's more nerves, or it's more painful to flex someone's hand like that than like that. But in a realistic scenario, this is the more likely scenario if you're going to have a distal fracture of the radius, the Coles fracture. All right, so this is really important. So really just take a big mental snapshot of this. Again, the radius is larger. It's articulating more directly. Notice it articulates with these two carpal bones right here, the scaphoid and the lunate, and the ulna is smaller. And then there's a little bit of a gap right here. We have our carpal bones, our metacarpal bones, proximal phalanges, intermediate phalanges, and then distal phalanges. In between the metacarpal and first phalange, we're going to have the MCP, metacarpal phalangeal joints. And then we have our interphalangeal joints. Well, we have the proximal interphalangeal joint, and then we have the distal interphalangeal joint. I would use, this is like the best mnemonic ever made. So starting here, so long the pinky, and it's nice because we're at the pinky. Here comes the thumb, and it's nice because now we're at the thumb. So I find that incredibly useful. So if someone, someone gets mad, punches a wall, as you do, you're highly likely to break the metacarpal bone in your fourth or fifth digit. That's your ring or pinky finger. Again, your thumb is 1 and your pinky is considered 5. So you can see that here. This is a boxer's fracture. What's wrong with this is that this actually is just one large bone. This is just the scaphoid bone. What is this right there? That's our fracture. And we should be able to name all of these bones right here. So this is the scaphoid, lunate, so long the triquestrum. The triquestrum has the pisiform sitting like right on top of it. So this is actually two different bones, even though it looks like one. So along the pinky here, this is the hamate, and this is the hook of hamate. It kind of hooks a little bit superficially. So along the pinky here comes the capitulum, the thumb, the, oh gosh, no, I'm forgetting. Embarrassing. The trapezoid and then the trapezium. These are two different bones. It looks like one bone, so often that's difficult to see. So notice that this is one bone, or sorry, that's two bones. This is just one bone, and this is two bones. That's often tricky on X-rays. So this is a lot clearer when it's color coordinated. And so the scaphoid fracture that we see in this picture, these are by far a majority of the fractures of the carpal bones. So then we have the hook of hamate. We said that that's right here, or the hamate bone, and the hook of hamate is going to project superficially, shown here in purple, and the ulnar nerve is going to slide right past that. So if you damage the hamate or the hook of hamate, you very well could cause ulnar nerve compression and damage your ulnar nerve, which would affect your ring and your pinky finger. The pisiform bone, I don't know why I always thought of like. It's kind of the opposite of this, right? The princess and the pea, she sleeps on top of the pea. Well, this is the opposite because here the pea is sitting on top of the triquestrum bone. That's just, that's how I always thought about it. So it is, I think it's really useful to spot this one, to know where you are. The triquetral bone. So tri because it articulates with three carpal bones. Now there's other carpal bones that articulate with three or more bones, but this is the only one to articulate with three carpal bones. So we have the hamate, we have the pisiform, and then we have the lunate. All right, so just so we kind of know where we are, this is the metacarpal, how it would look, with our hand with all our skin attached, and then the bones that are underneath. So more proximally is the base, more distally is the head. Note as well that for all of your fingers, 2, 3, 4, 5, you have a proximal, middle, or intermediate, and a distal phalanges. But for your thumb, you only have a proximal and a distal, no middle, which means that you're only going to have one joint here, where you have two joints on your other fingers. And again, just a nice picture to see where we are. Here we have the metacarpal bones, and then here we were going to have the proximal phalangeal bones. So this would be sort of like right at the MCP joint, right distal to it. So again, we're going to look at a lot of hands. If they don't mention anything about posterior, assume you're looking at an anterior snapshot. Assume someone's in anatomical position, and just kind of imagine that with the thumb pointing laterally, and that's the easiest way to go about it. Again, unless they say otherwise, you can usually assume we're in an anatomical position. So here's our anterior view of the superficial muscles, and then our posterior view, and we're going to go through all of these. Notice that the anterior compartment, so the anterior compartment also are the flexors. There's also a little bit of pronation. And here we're going to extend, and there's going to be a little bit of supination. So these anterior flexors versus posterior extenders, and again, it's kind of silly because they're not all posterior. This brachioradialis is considered the posterior compartment, but it's actually on the anterior. It doesn't even extend, so we'll get to that. But these flexors on the anterior compartment versus the extensors, mostly on the posterior compartment, are separated by the cubital fossa shown here. With the pronator artery on the medial side and the brachioradialis on the lateral side, and kind of right in between the medial and lateral epicondyle. So good rules of thumb, the anterior compartment is for flexion and pronation. Everything's attached to the medial epicondyle. Mostly it's the medial nerve, a little bit of the ulnar, which we'll talk about. And mostly things have kind of a medial to lateral slant. So that's relatively consistent for the anterior superficial compartment. The posterior superficial compartment Things are in the lateral epicondyle. It's mostly extension, a little bit of supination. It's all the radial nerve. Very few things are as simple as all extensors are radial nerve. That is very helpful. The direction also changes too as we're moving across the posterior compartment. Things aren't always pointing in the same direction. It kind of sweeps in a counterclockwise orientation, which we'll see as we go through it. Also keep in mind that this is flexion and this is extension. And flexion typically, if you assume anatomical position and you flex your arm forward, you're making the angle between your forearm and your, I'm doing it right now, you guys can't see obviously, so do it at home. Your forearm and your wrist flexing, that should make the angle smaller. And then if you're pushing back, extending, that is going to make the angle technically larger. So we're not using the same thetas as they are here. Okay. So pass, fail, pass, fail. We're looking at the pronator teres right here, the flexor carpi radialis, the palmaris longus, and the flexor carpi ulnaris. Notice that everything is kind of moving medial to lateral, a little bit, even for the ulnaris. Also keep in mind that the ulnaris is named the ulnaris because it at the distal insertion site, it's on the ulnar side, which is the medial side. The carpi radialis is a little bit more on the radial side, on the lateral side. And the palmaris longus, where does that go? That goes into the palm. And anything that's a pronator or a supranator usually goes from the radius to the ulnar or the ulnar to the radius, and that's what we're seeing here. This is not going to the wrist, it's going between our two bones. So it's easy to spot a pronator or supinator based on that logic. Keep in mind as well that anything that's F, flexor, is going to flex. C, carpi, well, that's the wrist. And then radialis is going to be on the lateral side on the radius bone, and U is going to be on the medial side on the ulnar bone. All of these are going to play a role in wrist flexion. Seen right here. Flex, extend. Flex, extend. Very cool. All right, let's watch a fun little movie. Moving through. And play. Now I'm going to sweep around. Just note that on the posterior medial perspective view, you can actually still see the FCU, flexor carpi ulnaris. All right, so let's go through these one by one. Pronator teres, guess it? It pronates. So what position right now? We're in the supination position. And let's go ahead and pronate, supinate. Pronate, supinate. And then again, it goes from the ulna to the radius. Anything that does it is a supinator or a pronator. Flexor carpi radialis. It is a flexor. It flexes. Carpi, wrist. Now, if it's on the radial side, it's going to cause, you can think of this as wrist abduction, pulling away, or sometimes it's just called radial deviation. So here's our radius bone, and it's just going to kind of move that way. There's actually a better picture of this in a second, so hopefully this is clear. If not, I'm going to come back to a better picture of this in a second, and you can mentally reference that. And so these are the two actions of this particular muscle. Palmaris longus. So not actually everybody has this. So you can sometimes see it right here if you flex your wrist. Like 15% or something of people do not have that. It also doesn't insert on a bone. Most of these things have an origin and insertion on a bone. This thing technically inserts into the palmar aponeurosis, which you can kind of see right here. It is going to as well flex the wrist, but it's really not that important of a muscle. Obviously, if a bunch of people are missing, it must not be that important. Flexor carpi ulnaris. So again, there's going to be a lot of themes to how these muscles work. So kind of play along at home and predict what things do. Flexor, flexes, carpi, wrist, ulnaris. So in addition, it's on the ulnar side. It is going to cause a adduction of the wrist, or you can think of this as a ulnar deviation. So this is the picture I was referencing like 2 or 3 slides ago. This right here is our ulnar sort of medial deviation. Previously, we were doing a lateral deviation with the FCR. So imagine if this just went the other direction, that's what the FCR is doing. That's what I was trying to show with the other stupid GIF. Also, this is most things on the anterior compartment, and most of these flexors are the medial nerve. One of the exceptions, really the only exception, actually, there's so many exceptions, this is what makes this so hard. It's in the name. this is actually innervated by the ulnar nerve. I'm hesitant to say, oh, it's easy, it's in the name, because we will see an extensor carpi ulnaris, and you would think, okay, that one's also innervated by the ulnar nerve, but it's not. That one, again, the rule is that all extensors are going to be the radial nerve. So, yeah, cool. So again, everything here is the medial epicondyle, and if you repetitively, notice the motion that Tiger is doing here. These are all flexion motions. If you just flex the elbow enough, it can cause irritation, it can cause inflammation, that causes pain. This is known as golfer's elbow. So if we go a little bit deeper, so we've been looking at the superficial anterior compartment. Let's go a little bit deeper and cut away some of the stuff. First thing we're going to see is the flexor digitorum superficialis, and then under that we're going to have the profundus a little bit deeper, then the pollicis flexor longus, and then we're going to have the pronator quadratus right here. Again, you can kind of know, because this is going from the radius, the ulna, that this is either a pronator or a supinator, and we know that the anterior compartment is always going to be pronation. So let's go ahead and take a look at these. The superficialis and the profundus, very similar, a couple differences. We'll talk about them. The main one, which we're going to hit again and again, is the superficialis is the median nerve, while the profundus is a dual innervation. On the sort of pinky medial side, we're going to have the ulnar nerve, and on the lateral side, the digits 2 and 3, we're going to have the median nerve. So, again, the name is helpful. Flexor, it's going to flex. In digitorum, digits meaning the fingers, it is going to flex the digits. So this motion seen here is what these are going to achieve. It's mostly the proximal interphalangeal and distal interphalangeal joints. The superficial is a little bit more of the proximal, and then the profundus is a little bit more of the distal joint, which we'll see a little bit more in a second. Now, the MCP, the metacarpal phalangeal joint, is the lumbrical domain. We're going to cover this again and again and again, because it's really important to understand claw, hand, which we're going to see down the road. So again, if you're looking at the profundus, if you're looking at digits 2 or digits 3, this is digit 1, the thumb, these are going to be innervated by the medial nerve. And we said that the profundus goes all the way to the distal and causes flexion there. Well, the superficial is going to be a flexion a little bit more here. The superficial, it's all median nerve. So here we have 2 and 3, which are the medial nerve, and so you can isolate the medial nerve versus, and this should say median nerve, not medial nerve, median nerve. And then the ulnar nerve here is going to be 4 and 5. So there's a way to isolate the median nerve versus the ulnar nerve by looking at the flexor digitorum profundus. So differences, the superficial one is, it's superficial. And then the profundus, I always think of something's like profound, like, whoa, that's really deep. And if something's really deep, I feel like, you're going to see it all the way through to the end. Someone who's deep is going to go through the whole journey. Someone superficial might kind of quit early. So that's how I think of this. The distal one goes all the way. It doesn't quit. It goes to the end. It goes all the way to the distal phalange, while the superficial one kind of quits a little bit early. The intermediate phalangeal is where the insertion site is. Flexor pollicis, so it's in the name. Anytime you see pollicis, thumb. So flexor, it flexes, pollicis, the thumb. All right, teres, anytime we see the word teres, tubular, round, polished, smooth. So we see teres minor here in the back. I guess that's considered tubular. This is also considered tubular, and it's going between a radius and an ulna. It's going kind of a very, very lateral motion in terms of like how the muscle is projecting, while most of the other muscles are going all the way from proximal to distal. That's how, again, we know the pronators versus the supinators. The quadratus is kind of like a square shaped a little bit. So that's where the names kind of make sense a little bit. And again, both of these are going to, as the name implies, pronate. Supinate, holding sup, pronating, slapping. Moving on to the posterior superficial compartment. I remember this by the mnemonic, as if like you're in a game show. I'd like to buy 5 E's Alex. So I know that you buy vowels technically in Wheel of Fortune and he does Jeopardy, but nevertheless, B brachioradialis. Anytime you hear brachio, we're really just talking about the upper arm. And radialis obviously means we're going to the radius. And where does this go to? It looks like it's going to the radial side on the lateral side of the arm if you're in anatomic position. So that's the B. E, we then have a lot of extensors. Extensor carpi radialis longus. Okay, how do we know what this one is? Well, everything in the posterior compartment is mostly an extensor. It's carpi, it's going to the wrist. Radialis, well, it's also going to the radius, the radial side of the wrist. And then longus, well, the next one is extensor carpi radialis, and this one is brevis, right? This one is simply shorter. So the best rule of thumb for knowing which is, if you have two muscles and one's long and one's brevis, one's short, is just whichever one looks longer, right? If one is an intrinsic hand muscle and one goes up to the forearm, then the forearm one is the longest. In this case, they both are in the forearm, but this one is clearly longer, so it's longest. If you can't tell from there, then I guess the next best thing is the long one typically inserts at a more distal phalange than the brevis, than the short one. So those are good rules of thumb. So next we have so we have brachioradialis, extensor longus, extensor brevis, extensor digitorum going to all of the fingers. Then we have extensor digiti minimi. Well, your minimal smallest digit is your pinky, so this is just going to your pinky. Extensor carpi ulnaris, where does this go? This goes to your wrist and specifically onto the ulnar side. And then we have the aconius, which is not that important. So let's go ahead and take a look at all of these. We have brachioradialis, longus. Notice the long one and the short one, and both of these are going to the radialis. Then we have the digitorum going to, well, you guessed it, the digits. Then we have ulnaris going to the ulnar side of the wrist, and then aconius is randomly up there. Again, conius not so important. The brachioradialis is definitely the black sheep of the posterior superficial compartment muscles for two big reasons. One, it's not even really on the posterior so much. It's mostly on the anterior. That's one. And two, most of the posterior compartment is for extension, a little bit for supination. And this one we saw earlier, this one flexes at the elbow. So it's definitely the black sheep. It belongs, I suppose, because like all other things in the posterior compartment, it is innervated by the radial nerve. Next, the extensor carpi radialis longus and brevis. Which one is which? Well, you tell me. This one goes all the way up here. And this next one goes down here. Well, the one that goes further is L for longus. The other one is B for brevis, is the short one. Both of these go to the radial side of the wrist. So if we just think about the name, extensor extends, carpi means wrist. So this can extend at the wrist. We see this here. This is wrist extension. Anything on the radialis side is going to have radial deviation, which if you're in the anatomical position is abduction of the wrist if you keep the forearm still. And we see that there. Extensor digitorum, sometimes called extensor digitorum communis. This extends the digits. So for the flexor digitorum, we had a superficialis that went to the middle phalanges and a profundus that was deeper that went to the distal phalanges. Here we just have one. And it just it goes to both the middle phalange and to the distal phalange. It does extend at the MCP, the PIP, and the DIP. But it's mostly effective at extending the MCP joint. The lumbricals technically do a little bit of extension here at the DIP and the PIP. And I know earlier I said that everything that is extending is innervated by the radial nerve. I lied, the lumbricals are not. They're going to be really important. We're going to continue to talk about them. Okay. So extensor digiti minimi just goes to the pinky, extends the pinky. It abducts it a little bit too. This will be important later when we talk about Wardenberg's sign, but it's mostly just, as the name implies, extending the pinky. Aconius, not really a lot to write home about. If you could guess what this does, it connects the humerus to the the ulna here, and it's on the posterior side. That's just like the triceps. That's going to be elbow extension. But it's such a small muscle, it doesn't really do much. So it's really not that important for extension. It's kind of a weak muscle. So remember that all of these are on the lateral epicondyle. That's where their origin is. And you can guess where all the insertions are based off of, are they called ulnaris, are they called radius, are they called digitorum, etc. If you did a lot of backhands, if you think about the movement of a backhand during tennis, this is using all of the extensors. So if you do too many backhands or too many extensor movements, you get lateral inflammation of the lateral epicondyle, which is called tennis elbow, colloquially. Supinator, if we look at this, we see that it's connecting the ulnus to the radius, so that's always going to be supination pronation. So let's take a look at this. Let's go a little deeper. Here we go, connecting the ulna and the radius together. So let's go a little bit deeper. Take a look. So if we rotate this, notice that this is going to the side. Going to the side, that's abducting. This is going to the thumb, and it's going to the back digits. So that's going to be extending. One of them going to the farther digit is the long one. The other one going to the other the closer, more proximal phalange was going to be the brevis, and then this last one here is going to the middle finger. The indices is the pointer finger. So again, if we look at all of these, we see that we have the abductor. You can guess that this is the abductor because it goes all the way out on the side, and on the side is where we're going to be, you would assume that abduction is happening. Then we have things going to just literally the dorsum of the thumb here. These are going to be extenders. The one that goes not as far is almost always the brevis. The one that goes farther is going to be the longest. And then we have the one that's going to the pointer finger, which is going to be the indices right here. All right, anatomical snuff box is actually bordered by three of those four muscles that we just talked about. So the abductor pollicis longus, extensor pollicis brevis, and pollicis longus. Again, notice that the brevis goes shorter, longus goes further, and then the abductor goes a little bit more laterally, so it's probably going to be pretty good for abduction. So snuff is kind of like a dried, ground up tobacco that, I don't know, people, it used to be more in fashion to snort. And people would, I guess, put it in their anatomical snuff box to snort it. So that's where this name comes from. And a lot of important vasculature and nerves come through here. So the radial nerve comes through here and the radial artery. And the scaphoid bone, that carpal bone that is, responsible for 55% of carpal fractures, is also located in there. So if you extend and abduct your thumb is where you can, I think, see it most clearly. Abductor pollicis abducts. Extensor pollicis extends. So does whether you're talking about brevis or whether you're talking about longus. Extender indices is just pointing. Now notice that the videos also it liked to do the so the extended indices is not going to the pinky. The complete anatomy, for whatever reason, just puts this motion together. But this is important because remember that the indices and the digiti minimi both have their own extenders. Does that mean that the extensor digitorum does not go to those two because they have their own? No, that just means that these puppies have extra. And so we see that here that we have two extenders on these fingers, and we only have one extender on both of these digits, 3 and 4. Meaning that if you try to do this right now, go on, try to do it, and you will notice that that's pretty easy to do. If you try to do this symbol, it's a lot harder to get those. I mean, you can do it probably, but at least for me, it's a little bit more difficult. And that's because we don't have as many extenders there, and we're getting kind of contradictory messages to the muscle. So this is easy. This is hard. Anytime you hear the word pollicis, you should think thumb. Anytime you hear the word thenar, you should really just think about this little sort of squishy padding that you have just proximal to your thumb that contains a lot of the intrinsic muscle groups that control your thumb. And similarly, hypothenar is really just going to be all of the squishy padding proximal to your pinky that controls a lot of your pinky movements. So I keep talking about intrinsic, extrinsic, and that means what it sounds like. Intrinsic groups are the muscles that are sort of originate and are contained within the hand, while the extrinsic are going to originate and start in the forearm and then extend into the hand. So, extrinsic being things like abductor pollicis longus and pollicis brevis, and the ones that we just talked about. So the thenar eminence, this is like a super nerdy debate coming up. It's kind of like, is Pluto a planet or not? But the adductors, some people consider them part of the thenar eminence, and then some people don't. I think for your NBME, you probably should not consider them part of the thenar eminence, but I'm not really sure. So as far as I'm concerned, the thenar muscle groups and the hypothenar groups as well are always going to abduct, flex, and oppose specifically. Now, we also do have these adductors, and interestingly, these are going to pull the thumb in, and the interesting part is that they are innervated by the ulnar nerve, which is kind of weird but important. So flexion, extension for the thumb. Opposition really just means touching your thumb to your pinky. Then various forms of adduction, abduction, which you can kind of just think about normal abduction, adduction probably. 9 muscle groups for the thumb: 2 abductors, 2 adductors, 2 flexors, 2 extensors, and an opponent's muscle. Also keep in mind that if we have really the axial plane is like the transverse plane, it's just like a nice cross section. Oblique is really just any weird angle. So let's keeping that in mind. That'll help make sense when we're looking at the adductors right now. This is a nice horizontal line. It's a weird awkward angle over there, so that's why oblique and transverse. Pollicis longus, notice that it goes all the way. It's the long one, and the brevis goes shorter and is starting in the hand. Now, here is an exception. The abductor brevis versus the abductor longus. The longus actually here inserts on the closer phalange. Extensor brevis and extensor longus. And we peel back one layer, and we're going to take a look now at the opponents. So I just really do want to underscore that rule. So the main rule of thumb is whatever muscle is longer, you call that the longus and brevis. If there's 2 muscles that pretty much have the same name. The next rule of thumb is usually, almost always, except for I think that's the one exception, that pollicis abductor, usually the one that inserts at the more distal phalange is the long one. All right, hypothenar, all pinky stuff. Again, Pluto debate, is the palmaris brevis part of the hypothenar? I don't know. Who cares? I would probably say that it's not, but it might as well be, right? I mean, all of these muscles are working together, just like in the thenar example that we just had. Again, abduction, flexion, opposition are the main things. Palmaris brevis, abductor digiti minimi, flexor, and then the opponents. And if we loop around to the other side, this is now going to be an extrinsic group. We have the extensor digiti minimi. The lumbricals might be the most important muscle group, mainly because of all the nerve palsies that involve claws. They're also really complicated. Earlier, we saw the palmaris longus, which was kind of interesting because most things originate on a bone and insert on a bone, but those inserted on the palmar aponeurosis. These lumbricals, they do originate on a bone, but they insert on a bone, but they're going to originate on the flexor digitorum profundus tendons. See him coming right off the tendons there? Great. So I think if you make your hand kind of like you're going wah, 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 talking with a sock puppet hand, that is what the lumbricals look like. So very specifically, and this is high yield, they will flex at the MCP joint. The proximal interphalangeal joint, they will extend, and they will also extend here. And again, you can think of this as, I think, the one thing south of the elbow that is extending and is not innervated by the radial nerve. Actually, maybe just the arm in general. Pretty much everything extension is radial, but the lumbricals for digits 2 and 3 will be the median nerve, and digits 4 and 5 will be the ulnar nerve. Just a reminder that we are all giant meat puppets being, kind of pulled by, strings. MCP, PIP, DIP. Look at the flexion versus extension, just like we saw. Cool. Interosseous muscles, we have 2 types. We have the palmar interosseous muscles and the dorsal interosseous muscles. Both are innervated by the ulnar nerve. It's kind of weird because the ulnar nerve is mostly associated with the pinky, so this seems kind of random. Three different ways to remember them, which one abducts and which one adducts. I guarantee this will be a question, if not a couple. I think of like someone from PETA, like abducting a dolphin, and dolphins have dorsal fins. So the dorsal side of your hand is for abducting, the dorsal interossei. I also, think like, okay, palms are for bringing people together, right? Like you shake hands with your palm and you pray with your hands, and prayer and brings people together. And if you give someone the backhand, that's going to push you apart. And that reminds me that palms bring together, they adduct, and backhands, the dorsal is going to abduct, bring them apart. And then most people just go by DAB, dorsal abduction, here, palmar adduction. So take whichever one of those or trash all of them. Just make sure you know which side abducts and which one adducts. So why only three here? Because the whole idea of the palmar is that we're trying to bring things together. Bring them together to, relative to what? Relative to the midline of the third digit. So this one needs to come in, this one needs to come in, this one needs to come in. What about the thumb? Well, remember the thumb has that transverse and oblique adductor. It doesn't need its own interossei muscle. But the third digit's exactly where it should be. It's already in the midline, so it doesn't need a palmar interossei muscle to bring it together. And trace. Here we go. Nothing more to see, just bringing them together. This is what they do. All right, dorsal Y4, I don't know, because we need to bring, that one away, and that one away, and that one away, and that one away. And, of course, our thumb has its own abductor. Our pinky also has extra abductors as well, right? It's not like these are the only things abducting. These are the only things abducting, 2, 3, and 4, though. Definitely want functioning dorsal interossei if you're going to be doing fun stuff like that. Let's review all of those muscles, categorizing things based off of the action that they help out with. Now, you can probably get like 50% of muscle innervation questions right just by knowing that flexion is associated with the anterior compartment, and that's associated with the median nerve, and the extension is associated with the posterior compartment, and that is associated with the radial nerve. So that's 50%. But of course, you want more than 50%, so let's get into the nitty-gritty and all the exceptions. All right, so if you want to flex at the elbow, you have three muscles: biceps, brachialis, brachioradialis. The biceps and the brachialis, these are the anterior arm. Brachioradialis is a little bit, but again, remember, it's technically categorized as the posterior forearm group, and that's because and it's weird, it's innervated by the radial nerve. The other two are innervated by the musculocutaneous nerve. For the wrist, flexor carpi, boom, done. Palmaris longus as well. Remember, like 15% of people don't have this, and so it's less important. All of this is the anterior forearm. All of these are medial nerve, except one exception, is that the FCU, it's not too crazy because it is ulnar. This is innervated by the ulnar nerve. Fingers, digitorum superficialis, F for flexor. Of course, that is going to be flexion. Just think about it. And then flexor digitorum profundus. Which one is deep? It's going to be the profound one, right? And the profound is going to go farther. That inserts, and it's more for flexion of the distal interphalangeal joint. Both of these are the anterior forearm. Superficialis, all median nerve, baby, not medial, median. The profundus is a little bit weird because digits 2 and 3 are median and digits 4 and 5 are ulnar. Lumbricals are super weird but super important. These are going to flex at the MCP joint, and similarly 2 and 3 median, 4 and 5 ulnar. You want to flex your thumb, flexor pollicis, flexing the thumb. Longus, brevis. Brevis is short. It is going to insert on a closer joint, closer phalanges. It's also, they're not all intrinsic, but if it's brevis, there's a good chance that it's just an intrinsic short hand muscle. So it's in the thenar eminence. And then the longus is in the anterior forearm. Both of these are median, not medial. Extension, you want to extend at the elbow, triceps, posterior arm. Again, arm means upper arm, and this is the radial nerve. Radial is almost all extensions, except just the lumbricals at the MCP joint. You want to flex the wrist, extensor carpus, extensor carpus, extensor carpus. I don't care if it's ulnar, radialis longus, or radialis brevis, not important. All of these are posterior forearm. All of these are radial. Fingers, extensor digitorum, sometimes called communis. And then we have two more though. Remember, rock on, right? It's easy to do the rock on symbol because we have extra extensors in digits 2 and 5. And you can't see it right now, but I'm rocking on. So this is the digiti minimi and the indices. All of these are both posterior forearm and radial. But then we have the lumbricals. Lumbricals, again, are weird. They're complicated. Proximal and distal interphalangeal joints are going to be extended here. This is medial ulnar nerve dual innervation. You want to extend to the thumb, extend pollicis, posterior forearm, radial. Abduction. Abduction is at the elbow. We don't really have it. I mean, you could just think at like the arm in general. We have the deltoid. I guess we start 0 to 15 is going to be the supraspinatus. 15 to 90 is going to be the deltoid, and the deltoid, or 90 to like 180 or something, it's going to be like the trapezius. But okay, so we want to abduct now at the wrist. So we might also call this radial deviation if you're in anatomical position. Notice all of these are going to be carpi, carpi, carpi for wrist, and radialis, radialis, radialis. The flexor is in the anterior compartment. The extensors are in the posterior compartment. Anterior compartment is usually median, and then the posterior compartment is usually radial. Dorsal. Remember, we got 3 ways to think about this. You want to push people apart, smack them in the face with your backhand. That's a dorsum. You want to abduct a dolphin, which has a dorsal fin, or you can just think of dab, and then the dab is going to dorsal abduct. Weirdly, these are going to be ulnar nerve. Abduct, pollicis, I don't care if it's longus or brevis, doesn't really matter. It does matter if you want to just know where they are. This one's thenar eminence. This one's the posterior forearm. Posterior forearm is almost always radial, and thenar eminence is going to be medial. Adduction. So carpi, carpi, wrist, wrist. Ulnaris, ulnaris. So this is going to be an ulnar deviation, just kind of sliding your wrist inward. The flexors are in the anterior compartment, and then the extensors are in the posterior compartment. Again, this is one of those exceptions. I've italicized and bolded the exceptions, the weird ones. The anterior compartment is usually the median, but here we have ulnar. Not too crazy because, again, we do have U there. But it's a little crazy because look at this next one. The next one has U. You're telling me this one's not ulnar nerve? Yes, I am telling you that. This one is radial nerve. The rule of thumb there is not even a rule of thumb. It is a rule of the law of nature, and is that the posterior compartment is going to be the radial nerve. Palmar interosseae, you pray, you shake hands, you bring people together with your palms, or you can think of pad, you have padding in your palms, and pad, palmar, adduction. Also ulnar nerve, just like this one. Then we have the transverse head of the abductor pollicis and the oblique head. Remember, transverse lines go like this, and oblique lines go kind of at a weird angle. This is also going to be the ulnar nerve, pulling it inwards. Supination, biceps, yeah, they're for doing bicep curls, but they also supinate just a little bit. This is located really just not even, I guess, at the anterior arm. Yeah, it's just in your arm and the anterior arm. That's fair. The supinator is going to be in your posterior forearm. This is musculocutaneous, and this is a radial nerve. Pronation, it's in the name. Pronator teres. Remember, teres kind of looks like this. And then we have the quadratus, which kind of looks like a little cube. Anterior forearm, but it's deep. It's very deep. This is medial, and that's medial. This is just a picture of the lumbrical to remind you that here we are going to flex, and here we are going to extend, and we have median innervation at 2 and 3, and ulnar innervation at 4 and 5. Also would not hurt to know, if that wasn't complicated enough, worth knowing the origins and insertions. Moving on to the second part of the lecture, we're going to be talking about nerves, arteries, and veins. Let's start with nerves. And you can't really talk about nerve innervation of the upper extremities without talking about the brachial plexus. So this is referring to the nerves, how they intermingle and branch and merge in a really complicated fashion from the C5, C6, C7, C8, and T1 spinal cord levels. Note as well that C5 comes above the C5 vertebral level. The C6 cord root comes above the C6 level. It's not until you get to the thoracic that now things come below the vertebral level. Also, as they move proximal to distally, they get new names. So we have the roots, the trunks, the divisions, the cords, and the terminal branches. You can remember that with Randy Travis drinks cold beer. And the terminal branches, I like to think of these in the following order: axillary, musculocutaneous, radial, median, and ulnar nerve. So probably the best way to really just wrap your head around the brachial plexus is just to get used to drawing it. And now there's a lot of complexity we can put on, but let's just start with what I think is like the most important, just like a nice, simple drawing, and then you can layer detail on afterwards, but let's go ahead and start. Okay. Down some happy roots here. Some happy branches. So notice there's a little bit of like symmetry there to this. I just think of it as like a nice pattern, honestly. Okay. So we have the most important bit down, honestly. We have the roots, Randy, and then we have the branches, Beer. Specifically, this is the musculocutaneous, this is the axillary, this is the median, this is the radial, and this is the ulnar. Here we have just moving chronologically, C5, C6, C7, C8, and T1. Okay, well, how do we do the Travis drinks cold, the trunks, the divisions, and the chords? I don't know if you've ever been bowling, but you can get a strike or you can get a spare. And where these things start, this is where we're going to do an end. This is where we're going to do our branches. A couple little happy branches. So we have the trunks. Here we have the divisions, and here we have the chords. The most important thing now is really just what the names are. This is the superior. This is the highest one. This is the middle. And this is the lower trunk. Then the chords. This one is lateral. This one is posterior. So this always confused me a little bit. Lateral, posterior, and medial. With regards to what? With regards to the axillary already. We're going to see a picture of this. So here is the medial over there. Voila. So if you can draw this, you're in pretty good shape, honestly. There's other things coming off at other nerves, but this is the main skeleton that you need to know. All right, so this is a little bit more flair. If we just keep in mind that this is the, lateral, this is the posterior, and this is the medial too. A lot of these branches kind of make sense. Medial, posterior. A lot of this stuff goes to the back, which is the posterior, and then this is lateral. I'm not going to talk about this so much because we're doing this is the arm lecture, so a lot of this stuff is back or chest or things like that. All right, so dermatome is the sensory innervation that is associated with a particular spinal level. I notice that C5 to C6 just kind of moves. And then as indicated by the arrows in this particular direction. So that is, laterally from a proximal all the way to the distal part of the fingers, and then back up proximally on the medial side. You can then think about the myotomes. So the axillary nerve, people say that it's generated, it's contributed to by the C5, C6. This is C5, C6, C7, C5, C6, C7, C8, T1. This one's the same, and this is C8, T1. But honestly, I think the best way to think about these is, what are they mostly associated with? The axillary is mostly associated with the C5 myotome. The test, and keep in mind that there's a fair amount of flexibility. Everyone's, there's a little bit of overlap. It's not an incredibly precise science. It's kind of like a rule of thumb, general approximation when we're talking about dermatomes and myotomes. But the C5 myotome is mostly associated. If you came in with some sort of injury to your spinal cord and I wanted to see if your C5 myotome works, I would ask you to do shoulder abduction. Again, this is kind of associated with the axillary nerve, which does more than just shoulder abduction, but this is the main principal thing that we would test. Musculocutaneous, I think of this for C6 because the C6 myotome is associated with elbow flexion, right? We have the biceps and the brachialis. Radial is C7. We're looking at elbow extension. Well, that's, of course, the triceps. We're then looking at the median nerve. I don't know why I keep saying medial, median nerve. I was looking at things like wrist and finger flexion, which is going to be because of the median nerve innervates the anterior compartment. And then the ulnar nerve is going to be associated with T1, which is finger abduction. Remember, that is the dorsal because you would abduct a dolphin with a dorsal fin, or because the backhand is where you hit somebody with, and that's going to, push people apart, push fingers apart. All right, let's go ahead and just move through a couple of images just to get a rough idea of where everything is, the sort of landscape. C5, C6, C7, C8, T1, there we go, goes to the superior, middle, and lower inferior trunks. Divisions, not so important. All right, so now we're looking at the chords. Remember, everything, so you can kind of see here, everything is relative. It's named relative to the axillary artery. The medial is a little bit on the medial side. The lateral is a little bit on the lateral side. And this is kind of lateral too, but it's more lateral and it's posterior. So we give it the name posterior. The picture's a little bit confusing. Just these are not touching, of course. There's a little bit of distance separating those. We have another picture here in the second frame that I've removed the axillary artery. I don't know if that helps or makes it more confusing. But again, we have the medial. The axillary artery would be right in between. The lateral is touching it right on the other side. And the posterior is way back there the posterior. All right, so now we're going to look at the posterior cord. It branches into the axillary and the radial nerves. If you need to remember, this was we had something like this, bum, bum, and bum. This was the posterior cord in the middle, and it gives branches to the birth to the branches of axillary and radial. Moving to the lateral cord, this, remember, turned into the, again, we have kind of the same thing, bump, bump, bump. This became the musculocutaneous right there. And we see this here, the lateral is kind of becoming the musculocutaneous, and it's still going a little bit, but it's just like merging into the median. So it's kind of done once it makes the musculocutaneous. Moving now to the medial cord. The medial cord doing a very similar thing. It's sort of ending and becoming the ulnar nerve, but it's contributing as well to what is going to become the median nerve. And what we keep talking about, so here it is. So remember, we had the lateral cord, which became the musculocutaneous, the medial cord, the lateral cord became the musculocutaneous, the medial cord became the ulnar, the posterior cord became the axillary and the radial, not shown, but the medial and lateral contribute to make we had this, bum, bum, and actually, did we show this one? No, we didn't show this one. This was musculocutaneous, this is axillary, this is radial, and boom, this is ulnar. I'm probably going a little crazy drawing this so many times, but you just cannot draw it enough. It's really important to know this inside and out. It seems nitty-gritty, but it's high yield. All right, so here, remember as well that these two things are going to kind of like merge together to make the median, and that's what we're seeing right here. All right, axillary nerve. Axilla is your armpit, and this goes, through your armpit. It also goes through the quadrangular space that we talked about in the back lecture. And it snakes around, and it's, what's this big old muscle right here? That would be your deltoid. So this is going to innervate the deltoid mainly. The radial nerve. So about 2/3 the way up the humerus, the radial nerve is coming in. Remember, it has it comes from the same cord, the posterior cord that the axillary nerve comes from. It also kind of goes through the axilla a little bit. We'll talk more about that later. It snakes around about 2/3. So this is the top third, and this is the bottom 2/3 of the humerus. It snakes around, and then it travels down the lateral side. And it's called the radial nerve because, it goes ahead and it starts hugging the radius as it moves down. So here we just have a picture of the radial nerve and the axillary nerve. They're both in the armpit, but because the axillary nerve is higher, it's actually like cushioned by all of this fat and skin and muscles and whatnot. So if you put too much pressure, let's say you have like crutches and you're really bearing down for like weeks or months, you would actually damage the radial nerve before you damage the axillary nerve. That's a point of confusion for me as well. Sometimes it is claimed that you can damage the axillary nerve by compressing the axilla too much, but the radial nerve is a little bit more vulnerable. The axillary nerve, being around the glenohumeral joint, is actually more susceptible to damage from like a shoulder dislocation. So looking at the radial nerve, it snaked around about 2/3 the way up. Goes down what's called the radial groove, and it's going to pass the lateral epicondyle. So if you damage the lateral epicondyle, you theoretically could damage the radius. So the most likely point of injury is the midshaft fracture, because it gets really tight when it hugs around, and the axillary compression, like with crutches, for the reasons we just saw. It's because it's sort of right in there. If you touch your armpit, boom, you're touching your radial nerve. All right, so we know that it innervates the extensors in the posterior compartment. Technically, though, if I've said the radial nerve, it's not theoretically, it's semantics a little bit, but it's the posterior interosseous nerve and the deep radial nerve. So those, for all intents and purposes, at least to me, I'm just going to consider that radial nerve, but you might have to know the specific branch names for that. This would be, a salute would be wrist extension, a thumbs up would be pollicis extension. So it's going to come down now, and it's going to really not do anything for the palmar side. There's basically no sensory innervation. By the way, whenever we show this picture here, we're showing sensory innervation, not myotomes, because the myotomes, a lot of the finger movement, remember, comes from the forearm more than intrinsic muscles of the hand. So here, these pictures are showing sensation. So not a lot of sensation from the radial nerve on the palmar side. On the dorsal side, we get the thumb. You can kind of see here everything in, so so this purple here is going to be the radial nerve, and then the light teal, like green, is going to be the branches, effectively still the radial nerve. It goes to the thumb, check, and it goes to these, notice it goes to the first half of the fourth digit, just the fourth half. It does not, it stops right here, stops right there, and that's exactly what we see here. It does not extend past this line, and it does not get the whole ring finger right there. It only gets the lateral side, the side closer to the radial bone. So basically, I would say the dorsum of your thumb is basically where the radial nerve sensation is going to be. Musculocutaneous, boom, biceps. Not just biceps though, no, sorry, it is just biceps in the brachialis. Coracobrachialis, which does adduction, no one cares about that. Just remember that the biceps and the brachialis, yes, they do bicep curls and elbow flexion, but the biceps also is a supinator. Remember that. The musculocutaneous, the word cutaneous is in there, and it births an important branch, which is the the lateral cutaneous nerve, also known as the antebrachial nerve. Anytime you see the word cutaneous, we're talking about skin, and if you have nerves in your skin, they're probably for sensation. So your lateral forearm is going to be due in part to the musculocutaneous, this sensation there. All right, moving on to the ulnar nerve. So the ulnar nerve is going to be going down the medial side, and it's going all the way to the pinkies. And it's called the ulnar nerve because it hugs the ulna bone. Makes sense. If you ever bump your funny bone, it's of course not really a bone. It's just your ulnar nerve is going to pass down the medial epicondyle, and there's a region where it can, called the cubital tunnel, where it can be compressed, or if you bump it, you might have a pain or tingling moving down the side of your arm. That's the funny bone feeling. Now, if you have long-term compression and pain and tingling, that's known as cubital tunnel syndrome. So the ulnar nerve doesn't really do a lot for forearm innervation, but remember, there's 1.5 muscles that it does get. It does help with the flexor carpi ulnaris. What does this do? It flexes the wrist on the ulnar side, so there might be a little bit of ulnar deviation as well. But it also gets the profundus, not the superficialis, but the flexor profundus a little bit. Remember that the flexor digitorum profundus is dual innervation. For digits 2 and 3, it's the medial nerve. For digits 4 and 5, it is going to be the ulnar nerve. And keep in mind that this, because it's deep, goes further and it gets to the distal phalange a little bit more. So that's where we're going to have the most flexion, is the distal interphalangeal joint with the profundus. All right, ulnar nerve, once we get to our hand, we're talking about sensation here. It is going to, yes, it is going to innervate the hypothenar eminence, which would be muscles, but for sensation, it is just going to be your pinky and the first half of your fourth digit. We can kind of see that here, right? Everything there and here, we're just getting this medial half. You flip your hand over, now you're looking at the dorsum, boom. Ulnar nerve is easy because it's doing the exact same thing. Remember that it also gets the interossei, both dorsal and palmar, so which is kind of weird, but so anytime you want to spread your fingers apart or bring them together, that is going to be the ulnar nerve. Guyon's canal, so we have carpal tunnel for the median nerve, which we'll talk about, but Guyon's canal is where the ulnar nerve is moving through, and you can have compression here. The nerve moves through a very, very small passageway with the palmar carpal ligament as the roof, the flexor retinaculum as the floor, the pisiform bone, and then the hook of hamate are all gonna, it's not really shown so well in this picture, but they're gonna really compress down on this ulnar nerve potentially. Things like riding your bike is gonna, if you ride your bike a lot, you might get a little bit of Guyon canal compression. That's a common complaint with cyclists. Median nerve. So the median nerve is kind of like the ulnar nerve in the sense that it is moving down the medial side of the arm and of the arm. During the forearm, it's on the medial side, but it kind of moves. Well, the names are fitting, right? The names are really where things go distally at the wrist, right? If something's ulnar, it's going to be ulnar at the wrist. If something's radial, it's going to be radial at the wrist. And if something's median, well, it's going to be in the middle at the wrist. But at least for the arm, it's moving down on the medial side. It's a little bit more anterior, while the ulnar is a little bit more on the posterior side. It does move a little bit past the medial epicondyle, but if you're going to have damage, it's more likely going to be the supracondylar region for the median nerve. So the branches here, we have the anterior interosseous is going to get the deepest flexor pronator muscles for the forearm compartment. And unlike before with the radial nerve, where it was kind of like semantics, this is actually important because there is a difference between just the innervation of the superficial and the deep muscles. So here's a normal person who's been told to, kind of pinch their fingers together in this very specific way. Notice that we have the flexor pollicis here and the flexor digitorum superficialis and profundus. This is getting the proximal interphalangeal joint. That's getting the distal interphalangeal joint. What happens if I have a specifically anterior interosseous lesion or palsy? That means that the superficial muscles from the median nerve are being innervated, but the anterior interosseous is not being innervated. What's going to happen is this is specifically this is a deep right here, and this one is also deep, which means these are both AI, and this is AI. Well, this one is just median. Well, if I have a anterior interosseous specific, boom, this buddy is not flexing no longer because that nerve's out of commission. Same thing here, no more flexion. You still do have a flexion right there because the superficialis is going to be fine. I would imagine this isn't too common. I don't really know. I don't really know. What are the chances you hurt just the anterior interosseous, but not the median nerve? No idea. But also keep in mind the name. Here's our ulna, here's our radius, and this is the interosseous, between bones. Between bones, this is the membrane associated with it. And in green, so the purple here is the median nerve, and then the green here is going to be the branch, the anterior interosseous. This is going to get the medial side of the palmar hand, so it's going to be the first 3.5, and you can kind of see that here. And it is going to get just the digits of 2, 3, and then the first half of the fourth one. You can kind of see that here as well. Boom, boom, and just a little baby boom right there. Something called the recurrent branch of the median nerve, which is just going to innervate the thenar eminence for all of the intrinsic thumb muscle movements. Again, this is flexion, abduction, and opposition are for the thenar and hypothenar eminences. If something's ever recurrent in anatomy, it just means that it's going woo, and then it's kind of snaking backwards. And so this here is kind of going here and snaking back a little bit, which is why it's called recurrent. It sort of turns back on itself so as to reverse direction. Carpal tunnel syndrome, so it's kind of like the Guyana Canal. There's a lot of, this is a very tight passageway where the median nerve travels through. It's one of the most common nerve injuries, and you probably see a lot of it when you're doing rounds. Paresthesia, pain, numbness. Because you are compressing the median nerve, that means the recurrent median nerve is going to be not functioning, so which means it can't innervate the muscles in your thumb. If you're not innervating the muscles in your thumb, they're not moving, and if the muscles don't move, they basically just die away if you're not working them out by moving them. The sensation is still there because the palmar cutaneous branch actually exits and branches out, somewhere around here from the median nerve before it passes through the carpal tunnel. So if you have compression of the carpal tunnel, it won't actually affect the sensation. It's associated with pregnancy, diabetes, arthritis, and just repetitive motion. So if you're someone who's clicking around all day on the computer, you could get carpal tunnel. We have the Phelan maneuver, where you just push the dorsums of your hands together, or the Tinel maneuver, where you just sort of tap right on the carpal tunnel, maybe a little bit proximal. And if you have a tingling, that's a positive sign that somebody is, yes, they do have carpal tunnel syndrome, a compression there. Very high yield, I think, to know this picture, or just what it looks like. So we have this synovial sheath, which is kind of surrounding everything. And, this is the median nerve. This is flexors, right? So this is why we have our flexors in here. The superficialis, well, shouldn't be a surprise. They are superficial. How many fingers are going to be innervated by the superficialis? 4. We have 1, 2, 3, and 4. Okay, how many profundus fingers are going to be innervated? 4. Profundus is deeper. That's why this is deeper. 1, 2, 3, and 4. Median nerve is right here. This is going to be the side closer to the thumb. So this is the thenar eminence. And the side closer to the thumb is going to be the radialis. So that makes sense that the radialis tendon is close to the thenar eminence. And on the other side, we have the hypothenar eminence. So again, I think this is very high yield. And again, Guyon's canal is going to be right here. Okay, summary time. The radial nerve is on the lateral side of the arm. Technically, it starts on the medial position, but like 2/3 of the way up the humerus, it crosses over. And it's called radial because it moves, at the forearm and with the radius bone. The ulnar is always medial, and it's posterior at the upper arm relative to the median. And at the forearm, it's called ulnar because, it goes with the ulna bone. And then the median is medial, a little bit anterior in the upper arm, and then it, becomes median. It's kind of in the middle between things as we move into the forearm. Now, injuries, high yield, radial nerve, lateral epicondyle, makes sense, it moves by there. Axilla damage and midshaft fracture. Ulnar bone, medial epicondyle, makes sense, it moves by there. A hamate fracture, remember that is the medial edge for the Guyon canal. And cubital tunnel syndrome, and the Guyon canal compression, something like riding a bike and putting your, too much pressure on your wrists on the handlebars. Median, it's also kind of like a medial epicondyle injury, but technically it's a supracondylar, they might say that. Carpal tunnel syndrome is probably the main one. That's really important that you'll see, or just like a wrist laceration of someone cut their hand cooking or something. Forearm muscle innervation. The radial nerve gets things in the posterior. These are typically extensors or supinators. The ulnar nerve really doesn't do much here. It gets a little bit of the flexor digitorum profundus, only digits 4 and 5, and flexor carpi ulnaris. Remember that extensor carpi ulnaris is not associated with the ulnar nerve. It, like all other extensors, is the radial nerve. Median nerve, anterior compartment, this is flexion and pronation. Remember that for the deeper ones, we do have the anterior interosseous, which is different. Most hand movements, all extensions, except for the lumbricals, which will extend at the PIP and DIP. For the ulnar nerve, digits 4 and 5, flexion. And abduction, adduction, very weird, very important. Interossei muscles is ulnar. Median nerve, digits 1, 2, and 3. Yes, 1, because remember, it's got the pollicis longus and pollicis brevis, I think. But then 2 and 3 because we have the flexor digitorum superficialis, that's all median, and then the profundus, which is just digits 2 and 3 is for the profundus. For the hand sensation, the lateral hand, the dorsal side, is associated with the radial nerve. For the ulnar nerve, it's always the pinky and the ring finger, whether you're palmar or dorsal. For the median nerve, it's a little tricky. It's all palmar on the medial side, but on the dorsal side, it's only the tips of fingers 2 and 3. For the axillary and musculocutaneous, axillary is associated with surgical neck fractures and shoulder dislocations. Some people say axilla damage, but we've showed earlier that technically it's so high, it's cushioned by all this muscle and fascia and whatnot, that it's not. It's more likely the radial nerve would be the one damaged with like crutches or something, or the Saturday night palsy, which we'll talk about. The musculocutaneous is rare, but like upper trunk damage. So if like you rotated a newborn's neck, or someone falls on their neck, or someone tries to hang themselves and fails, but does permanent damage because of the stretching of the upper brachial plexus. Our muscle innervation for the axillary is deltoid and teres minor, but mostly just deltoid, or most importantly deltoid. This is going to cause the abduction 15 to 90 degrees. Musculocutaneous, bicep, and brachialis and coracobrachialis. Coracobrachialis, a little bit of adduction, nobody cares. Brachialis, definitely elbow flexion, we care about that. Bicep, remember, it's also supination. Axillary sensation is the lateral arm, the upper arm. The musculocutaneous sensation is the lateral forearm. All right, maybe the highest yield thing of this whole lecture, everything else has been an important foundation. It's important to know where the nerves are, what the muscles do, but really I think a lot of the questions are, kind of like a knockout gene. If you knock out this gene, what happens? If you knock out this nerve, what's the consequence? This particular slide is actually not on the test at all, but like the nerve injuries, is on the test. I just thought this was interesting. 66% of nerve damage apparently is in the peripheries. I don't know why. I'm just totally guessing. I got this from some paper. I didn't really read the paper, but maybe diabetes, peripheral neuropathy. Your guess is as good as mine. Median nerve, I'm guessing carpal tunnel compression is so this is the main nerve damage, the median nerve. I also found it interesting that it's the non-dominant hand for most people. 60% of people's nerve damage is on the left side. Weird, not important. Now, this is important. Radial nerve injury. So if you know what the muscles do, if you know what nerves innervate what, all of this honestly should make sense. You shouldn't have to memorize this if you understand the foundation. I think that's very important because otherwise it becomes very difficult. It's already difficult, but it becomes more difficult. So remember, radial nerve is like all the extensors. So no extension. The big one is wrist. No wrist extension, which means that the wrist is just going to drop. This here is decreasing the angle there. That is technically flexion, because if you're not extending, you're flexing. That's the big one. It's called wrist drop. Sometimes they call it crutch palsy because we know that damages the radial nerve. They call it Saturday night. This one's silly. Like what kind of alcoholic maniac thought about like, oh yeah, like, how Saturday nights are. Who gets so drunk that they, look, we've all had our nights, but who falls asleep in a chair like that so bad that they damage their armpit? I don't know. I've never seen that. But that supposedly is the Saturday night palsy. Imagine somebody showing you their wedding ring or ashante, that's also wants you to kiss their hand. That's a wrist drop as well. Loss of sensation over the posterior arm and forearm, and loss of sensation, remember, on the lateral thumb side of the dorsal hand. Not much going on for the palmar hand. So this is all radial injury. Also decreased grip strength, which might seem weird, but if you ever hold a tennis racket, if you really want to hit something hard, you actually have to extend your wrist a little bit to get maximum action of your flexors to get the best grip on it. So a little bit decrease in grip strength as well. All right, so to understand ulnar, proximal versus distal lesions and medial, I keep saying median, you really have to understand lumbricals. So let's take a look. We know that lumbricals in red are going to flex at the MCP joint. They're going to extend here at the PIP and the DIP joints. Extensor digitorum always extends at any of these joints, but it's most effective at the MCP joint, this one. Flexor digitorum superficialis is mostly here, and profundus is mostly there. All right, so let's say that this picture here shows like a relative balance, like a nice equilibrium between all of these forces, and this is like a normal resting hand position. All right, so how does this shape change? Remember that if you activate the lumbricals, you get this kind of like sock puppet, look here. Some people think of L for lumbricals, but this is flexed, this is extended. All right, what if we had this is just me making my hands look funny, but if you had a distal nerve injury, so your lumbricals in your hand, like let's say you cut your wrist really badly or something, your lumbricals might not be working. So you get this kind of claw thing. So here, it's difficult to see, but we have here you have flexion, extension, extension. Well, it's really just the opposite if you don't have lumbricals working. Now I'm going to have extension, flexion, flexion, and we get this kind of claw hand. It is a natural consequence. However, what if we have a proximal nerve injury? So like I damage the median or ulnar nerve way up in my arm, proximal. Now I don't have lumbricals, sure, but I also don't have the flexor digitorums. That means you have absolutely no flexors going on in your digits. So you only have extension. If you only have extension, well, you know what? You're going to do this little salute looking thing. Only have extension. Even though the extension digitorum doesn't do much in the interphalangeal joints, it's still something, and it doesn't have anything to counteract it right now with a proximal injury. Okay, so again, let's look at the ulnar nerve specifically. If I have a injury here, like at the wrist, I take out everything in the hand basically. But what if that's a distal injury? What if it's a proximal injury? Now the injury's up here. Well, now I also don't get, ulnar nerve doesn't do a lot in the forearm, but remember, it does do the carpi ulnaris, and the profundus is half innervated by the ulnar nerve for the digits 4 and 5. So all ulnar injuries, no matter where they occur, you are going to lose sensation in your ring and pinky finger. And your hypothenar eminence. Your hypothenar eminence will also basically waste away because the muscles aren't being used because you need the ulnar nerve to innervate them. So that means your pinky is going to be bad. No flexion, no opposition, no abduction. Your interossei, remember, it's always weird, but that the interossei are by the ulnar nerve. That means you cannot abduct or adduct your hands. And they will probably, this is very noticeable. They'll just say in the vignette that there is muscle wasting in the hand. And you go, boom, ulnar nerve damage. All right, so if there is a proximal injury, proximal meaning like it's at like the, elbow or something, the medial epicondyle fracture. So now we don't have lumbricals and we don't have the flexor digitorum profundus to go to 4 and 5. So it means there's no flexion at all. And you know what? If there's no flexion at all, that means you only have extension. The way that you can see this is somebody's hands would normally all 5 fingers could be extended. But if you tell them, hey, can you try and make a fist? You know what works fine? Digits 1, 2, and 3. Those will make a fist just like they normally would. But digits 4 and 5 cannot flex at all because they don't have an FDP and they don't have a lumbrical, so they stay up. And it kind of looks like you're making the OK sign. So upon a request to make a finger flexion, you could tell that somebody had a proximal ulnar injury. So again, this is not the rest position. You have to ask them to make the fist or to flex all their fingers. Also remember that the FCU is innervated by the ulnar nerve, which means we don't, we have a flexor carpi radialis, so we can still flex our wrist a little bit, but it's weaker without the ulnaris helping. Also, remember that the ulnaris also kind of has a medial ulnar deviation, which means if I only have wrist flexion with the radial side, that means I'm actually going to have the equilibrium's thrown off, and you're just going to have a radial deviation whenever you flex your wrist. Now, if you have a distal injury, meaning that the forearm is fine, it just happened in like your palm or something, like a hamate fracture or whatever. Now it's only the lumbricals that are not working. Your digitorum profundus works fine. So you will now have extension of your MCP joint and flexion at the IP joints, and this is called the ulnar claw. So this is the position important at rest. These pictures, this is 1, 2, 3. These are just fingers normally just extended, but that is just the natural position once we take out the lumbricals, as shown on the previous slide. All right, so there's more to figure out the ulnar nerve. Wardenberg sign. So remember, ulnar nerve is palmar interossei, and your palms bring people together. So this is adducting. So we don't have any adduction. Also, there's the extensor digiti actually, yes, it mainly extends as indicated in the name extensor, but it also abducts a little bit. And if I don't have the palmar interossei to abduct, and I don't have the abductor because I don't have the ulnar nerve of the pinky in general, that means there's actually going to be a teeny little bit of abduction of the little finger, and it looks like this. And this is called Wardenberg sign. So it's not actually really the Spock thing, because it really should just be this pinky, not this other one. Ulnar nerve, second sign. It's called Froment sign. So if you really want to get a good grip on something, usually actually you just use adduction. I think of like if you're pinching someone's cheeks here, you're actually adducting your thumb more than you're flexing your thumb. So this would be a normal pinch. And this would be a normal pinch, adduction. But if my ulnar nerve isn't weakening, remember, it's kind of random as well. There's a lot of random things with the ulnar nerve. It's the transverse head and the oblique head that are abducting, pulling in. What is that innervated by? The ulnar nerve. So you actually can't adduct the thumb. And if you can't adduct the thumb and you want to pinch someone's cheeks, or you want to make this little finger sign, you want to grab whatever this random like card is, you now have to notice that this is adducted, but it's kind of straight. Boom, now I have to have a little bit of flexion if I want to grab onto something. So if you ask a patient to grab onto something with their thumb, the way they would normally pinch it, and they have to flex their thumb, that's Froment sign, and that's because the ulnar nerve is inhibiting the adduction of the pollicis. Proximal versus distal for the median nerve. Proximal is the wrist, distal is the wrist, and it is just the hand muscles. But if I make it proximal, boom, now it also includes the forearm muscles. Medial injury. All medial injuries, the median nerve is going to innervate the pollicis. Specifically, if we think about the abductor pollicis is innervated by the median nerve. Remember that we just said the adductor is innervated by the adductor ulnar. And yes, we do have technically, we might have a abductor pollicis longus, but it's just not enough to overcome without the brevis adductor pollicis. The two large adducting muscles are just too much for it, and it pulls your thumb inwards. It adducts because we lost one of our abductors. This is called the ape hand, because apes have, their hand like this a little bit. You can't innervate your thenar muscles, so your padding right proximal to your thumb is going to go away. So wasting there, and without this, you have trouble opposing, flexing, and abducting your thumb. Loss of sensation to digits, not 4 and 5, that's a typo. Loss of sensation to digits, I would say 1, 2, and 3. Yeah, shame on me. That should be 1, 2, and 3. So if we have a proximal injury, like a medial supracondylar fracture, now we don't have the flexor carpi radialis, but like we just saw in the last one, right? A lot of this is just flip of the ulnar nerve injury. You still can flex, but now we just have the ulnar flexor muscles, so we're going to have a little bit of ulnar deviation every time we flex our wrist, in addition to having weaker flexion because you don't have one of your flexor muscles. Now we don't have the digitorum profundus, and we don't have the lumbricals, so we should have no flexion of the fingers, meaning that they're going to be extended. So this, again, it's just like the ulnar one. There's a lot of symmetry here. Someone's fingers are normally going to be all 1, 2, 3, 4, 5. They're normal. But if you say, hey, can you make a fist? Well, now digits 4 and 5 are fine because it's a median nerve injury. But digits 1, 2, and 3, they cannot flex. So this is going to look like what the Pope does when he blesses people. So this is the hand of benediction sign, specifically upon finger flexion, not at rest. Now, if we have a distal injury, that means that the flexor muscles in the forearm are fine. It's just the lumbricals that are out of business. And if that's the case, now you're going to get this claw thing. And you're only going to get it for the two lumbricals that are taken out of commission. That is 2 and 3. And we get an ulnar claw. And this is at rest. Axillary injury. Again, we've been through this. I don't know why I was so obsessed with this, but you have the radial nerve, which comes down here, and we have the axillary nerve, which is up there. They're both in the axilla, but the radial nerve is We have things like the latissimus dorsi here. So this is latissimus dorsi. Inferior to that is the radial nerve. Superior to that is the axillary nerve. So you know what? If you have crutches pushing right into there, well, you're going to cushion with your latissimus dorsi, your axillary nerve. So it's mostly your radial nerve that's going to be damaged. So the radial nerve is damaged by the crutches and being drunk and falling asleep. So your armpit's on a chair. Okay, how can we damage the axillary nerve? Probably the main way is that you have a shoulder dislocation, but also damage to the anatomical neck of the humerus. And 15 to 90 degrees, you're going to have a hard time abducting your shoulder, in addition to having, and so we have this atrophy here, in addition to the lateral part of your arm sensation is going to be gone. Muscular cutaneous, mostly just good for impressing the ladies at the beach with your biceps, but remember it also supinates. So without the supination, you might have a more pronated. So you have a hard time supinating, and you might just have a pronated stance. All right, so let's go through a couple of these. So one, we'll table this. We'll come back to herbs, and we'll also come back to this. Let's look at 3. If you had a damage here on the posterior cord, well, that's going to take out the axilla and the radial. So we'll just do 3, 5, and 6 together. Without 5, we just did this. You don't have any abduction. You don't have any lateral of your upper arm. Without the radius, you don't have extension. You don't have you have the wrist drop. You don't have sensation over the dorsum side of your thumb. So if it's just 5, it's just the axilla. If it's 6, it's the radial. If it's 3, it's going to be both of those together. And what about 4? 4 would be like winging of the scapula, because the long thoracic, innervates the serratus anterior. Remember that you can also have winging if you have the latissimus dorsi. That's not working. All right, we're looking at 7. 7, you can't do. We just did this. You can't do bicep curls, and you're going to have a supination issues, and lateral forearm is going to have issues with sensation. 8. The main thing for 8 is you just can't flex. You can't flex your wrist. You have a hard time flexing your fingers. Depends if it's proximal or distal, right? But you might have the Pope's blessing. You might have the medial claw. 9 depends if it's proximal or distal, but you have a hard time feeling things with your pinky, muscle wasting, and just your hand in general, right? Because the dorsal and palmar interossei are not functioning. And just remember your myotomes. C5, the test is mostly abduction. Is there more than just abduction? Yeah. And again, it's also very vague and imprecise, the myotome levels, but mostly the abduction is what we should think. Elbow flexion, elbow extension, finger wrist flexion, and T1 finger abduction. And again, the reason I like to number the nerves the way that I do the terminal branches, because this is axillary. That's number 1. That's very much associated with C5. Then we have the muscular cutaneous. That's associated with elbow flexion. Then we have the radial. Then we have the medial, median, whatever, who cares? Finger abduction, this is going to be ulnar. All right, so Erb's palsy. If we have damage right here, upper trunk of the brachial plexus injury. So first, how can you do this? If you're delivering a baby and you don't know what you're doing and you just kind of twist the neck, that's not good. If someone tries to, commit suicide and they live, but they're, maybe they jumped off a stool or something, and you can kind of get the same impression here. If you just apply too much force to your neck, that can rip and tear the upper brachial plexus. So let's think about why we would get what's called the waiter's tip. So we just saw the myotomes, mostly no abduction or flexion, but remember it's a little bit more complex than that. We can really just think of no deltoid or no musculocutaneous, but also keep in mind that these feed things like the long thoracic and the suprascapular nerve there. So we're going to have more things that are going to happen. But no deltoid means no abduction. No musculocutaneous means your arm is going to be, you cannot flex at the elbow, so you have to extend at the elbow. So if I cannot, so I have an adducted arm that is extended. What else does the musculocutaneous do? It supinates, so it's pronated as well. And the, infra spinatus is going to be associated with lateral rotation, so it's medial rotated, and the long thoracic is going to cause winging, et cetera, et cetera, et cetera. The main things to know is adducted, extended, and pronated. You get an arm that looks like this, and I guess it's supposed to be like a sneaky waiter, kind of asking for a tip, trying to be like subtle about it, but saying I want more of a tip, kind of behind the back. That's where the name comes from. Lower trunk tear, C8 to T1. This is Klumpke palsy. Remember, if we go back to what are these, this is going to be the median nerve and the ulnar nerve. Well, that's all of flexor digitorum profundus, so we're going to get a claw on all of our fingers. And no flexion means all of our forearm muscles are going to waste away. How can you get this? If again, you got someone who has no idea what they're doing, just yanking on the baby to come out, bad idea. If you fell off a cliff and then try to, like in the movies, they just grab on and no problem. But just think about the amount of force that would be exerted upwards. It would break right here, might tear your lower part of your brachial plexus. Arteries, certainly lower yield than nerves, but worth a talk. Okay, so we have the axillary artery. Things are typically called axillary when they're near the axilla. So this is axillary artery, turns into the brachial artery. It's also called brachial, pretty much anything associated with the upper arm, really just called the arm. Forearm is the distal arm. So the brachial is associated with arm, axillary is associated with the axilla, so the name transformation isn't so crazy. Note that the brachial artery sort of branches off to form what's called the deep brachial. This makes sense because it's deep. It's the brachial is a little bit more superficial. More important though is that the deep brachial sort of snakes around. It's actually coming off right when this little sneaky radial nerve starts to also 2/3 the way up the humerus snake its way around. The deep brachial sort of follows it and parallels it down the humerus. The deep brachial, it's just a silly semantics thing, becomes the radial collateral, which becomes the radial recurrent. The second we see recurrent, what do we know? Recurrent means that something is coming up if it's recurrent. So we can already anticipate that there must be another blood vessel here that's then snaking upwards to form a collateral circulation to, there's an anastomosis between these two arteries. That would be a guess if it's called recurrent. And we only see it going down here, that it must be going upward for a different direction. Okay, the brachial artery is, of course, where we are going to take blood pressure, just slightly above the cubital fossa. That's where we would put the cuff. The brachial artery actually goes right through the cubital fossa. Once it goes past the cubital fossa, it then branches into the ulnar branch near, of course, the ulnar bone, and then the radial branch, of course, near the radial bone, B for bone, R for radial, radius. And then what do you know? The radial recurrent, this is what goes up and is going to meet we can even think about it. It's called collateral, right? I mean, it's literally called collateral, so it's collateral circulation. So the fact that it's collateral and recurrent should have clued us off. But yeah, so the radial recurrent means with the collateral, which means with the deep brachial, which, again, around the time that the radial nerve sort of splits off, is where the deep brachial breaks off from the regular brachial. All right, we also have an anterior interosseous. Again, that's going to be next to the interosseous membrane, between bones. This is really just the median nerve here. There is, previously we had an anterior interosseous and a median. Here it's just the anterior interosseous until you get to the wrist. And then actually once we have or move past the interosseous membrane, now we just call it the median artery. And the scaphoid bone, remember that this is the one that 55% of carpal fractures of the scaphoid bone. It's located in the anatomical snuff box. If you break this, you can have avascular necrosis of distal parts of the scaphoid bone, which you can picture a little bit better here, right? If we have blood going here and then there's a fracture, it's difficult to get blood supply then through that fracture to this distal, farther away parts of the bone. You can see it here as well. Veins. Veins also not super high yield, but you should know them. So the distal veins, for whatever reason, run in pairs. I'm not really sure why, but yeah, ulnar pair, radial pair, median, antebrachial. It's kind of running in a pair a little bit. They're not parallel and they're not as close to one another. Very much like the arteries, the basilic in actually, no, sorry, not. What am I talking about? Not like the arteries. We have this thing called a basilic vein, which is just a large vein, much larger than the brachial vein, that runs down the medial side of the arm. The brachial veins are much smaller. These are also going to be twin veins. And again, brachial typically means that we're part of the arm, not the forearm. So that's more or less where it's located. Cephalic vein is going to be kind of the counterpart to the basilic vein, but it's on the lateral side. Large vein, lateral side. Not a counterpart here for the artery. So subclavian becomes the axillary. And the axillary is going to move past the axilla. That makes sense. But it's not till we get to, around the time that the deep brachial forms and the radial nerve loops around that we actually say, okay, enough's enough. Let's stop calling this the axillary vein and let's call it the basilic vein. So we have the brachial vein and the basilic vein are going to kind of merge, and it's then the axillary vein as it moves up. The cephalic vein is going to merge with that. Still axillary, but over here it's now going to be called subclavian. The medial median cubital vein here between the basilic and the median antebrachial. So you can really just think it's going to be at the cubital fossa, and then it goes to the medial side. This is the medial side over here. This is the lateral side. And this is really where we're going to inject drugs. You, of course, want to put them in veins, not arteries, to make sure that the concentration is honkadory, and where we might draw blood and median cubital vein. And everyone's vascular is a little bit different. Nerves might be a little bit different. Arteries might be a little bit more different. And then veins might even be the largest amount of difference. But just keep in mind that the cubital fossa is where we might find the brachial artery, the median nerve, and here the median cubital vein here, where we're going to draw blood towards the medial side, hence the name. Well, I hope that was helpful. Thanks for watching.